Bismillah ar-Rahman Rahim. The topic assigned to me is the initial evaluation laboratory workup for hilar cholangiocarcinoma. The goals of preoperative evaluation are to rule out benign causes of hilar obstruction, to identify patients with early stage disease who may benefit from surgical therapy, and to provide palliative biliary drainage and systemic treatment to those with advanced disease and preserved performance status. Pathologically, there are three subtypes of extrahepatic bile duct adenocarcinoma: sclerosing, which is more than 70%, nodular 20%, and papillary, that is 5 to 10%. The vast majority of hilar cholangiocarcinoma are mucinous adenocarcinoma with a nodular or sclerosing growth pattern that involves the rich lymphatic plexus around the bile ducts early in the course of disease. Over time, hilar lesions can progress locally with the formation of a mass that frequently involves critical hilar vascular structures. Less commonly, patients present with a papillary form that tends to have an endobiliary growth pattern and a more favorable prognosis. We know that 20 to 30% of cholangiocarcinoma is intrahepatic, while 70 to 80% is extrahepatic, and out of these, 50 to 60% these are perihilar, and 20 to 30% these are distal cholangiocarcinoma. If you go to the history, signs and symptoms of cholangiocarcinoma include the following: jaundice, clay-colored stools, bilirubinuria, that is dark urine, pruritus, weight loss, and abdominal pain. The most common manifestation of bile duct cancer is jaundice. The obstruction and subsequent cholestasis tend to occur early if the tumor is located in the common bile duct or common hepatic duct. Jaundice often occurs later in perihilar or intrahepatic tumors and is often a marker of advanced disease. The excess of conjugated bilirubin is associated with bilirubinuria and ecolic stools. Coming to this, another symptom, the pruritus. It is usually preceded by jaundice, but itching may be the initial symptom of cholangiocarcinoma. Pruritus may be related to the circulating bile acids. The another symptom, that is of weight loss. It's a variable finding. It may be present in 1/3 of patients at the time of the diagnosis of cholangiocarcinoma. Coming to the abdominal pain, it's relatively common in advanced disease. and it often is described as a dull ache in the right upper quadrant of the abdomen. On examination, if the cholangiocarcinoma is located distal to the cystic duct takeoff, the patient may have a palpable gallbladder, which is commonly known as Kruiser sign. An abdominal mass or palpable lymphadenopathy is uncommon, but hepatomegaly may be noted in as many as 25% of patients. The lab studies, these are traditionally the liver function tests, which include bilirubin, ALT, AST, alkaline phosphatase, and GGT, and the tumor markers, which includes carbohydrate antigen 99, and we will talk about if alpha fetoprotein can be of any help. Direct conjugated hyperbilirubinemia occurs early in extrahepatic cholestasis, whereas it occurs later in the perihilar or intrahepatic tumors and is often a marker of advanced disease. In patients with perihilar cholangiocarcinoma, the preoperative bilirubin level may effectively reflect the severity of disease and provide prognostic information. In patients with a low bilirubin, which means less than 12 mg per deciliter, 1, 3, and 5-year overall survival rates after resection are by and large 76%, 36%, and 22%. In those patients with bilirubin high, that is more than 12 mg per deciliter, corresponding overall survival rates, that is 1, 3, and 5 years, these are 54%, 14%, and 0%. It means the pre-op bilirubin levels, if it is less than 12 milligram, it has got relatively good prognosis, good survival rates as compared to those where this bilirubin level is more than 12 milligram. In addition, rates of early tumor recurrence are significantly higher in patients with high preoperative bilirubin levels than in those with lower levels. Coming to the ALT and AST, levels of ALT and AST may be normal or minimally elevated. Alkaline phosphatase levels usually rise in conjunction with the bilirubin levels. Higher the bilirubin levels, higher is the alkaline phosphatase levels. GGT, because alkaline phosphatase is of biliary origin, the GGT is also elevated. Biochemical tests of liver function, that is albumin and PT, these are normal in early disease. With prolonged obstruction, the PT can become elevated because of vitamin K malabsorption. Hypercalcemia may occur occasionally in the absence of osteolytic metastasis. Coming to the tumor markers, the carbohydrate antigen 99, CA99, its levels may not be accurate in the setting of hyperbilirubinemia, but may be relevant later in the evaluation after biliary decompensation. A serum CA99 level greater than 100 units per ml, remember normal is less than 40 units per ml. If it is more than 100 units per ml, it has 75% sensitivity and 80% specificity in identifying patients with primary sclerosing cholangitis who have cholangiocarcinoma. So if a patient with primary cholangitis has higher levels of CA99 more than 100, it has got 75% sensitivity and 80% specificity that these patients has cholangiocarcinoma. It can be elevated in pancreatic and bile duct malignancies as well as in benign cholestasis. Otherwise, it can be misleading. In PSC, an index of CEA, carcinoembryonic antigen, and CA99 has an accuracy of 86% using the formula CA99 plus CEA multiplied by 40. By using this formula, it has got accuracy of 86%, showing the patients having cholangiocarcinoma. In one study, patients with primary sclerosing cholangitis values were more than 400 in 10 of 15 cases of cholangiocarcinoma, but in none of 22 comparable cases with no tumor. Means there were 22 control cases when there were no tumors, and in 15 cases where the PSC they were having tumor, this formula gave the sensitivity of in 10 out of 15, it detected that the cholangiocarcinoma is there. 10% of patients may be Lewis antigen non-producers and thus will not secrete CA99. What about alpha-fetoprotein? Cholangiocarcinoma does not produce alpha-fetoprotein. So to conclude, dear colleagues, for the workup of hilar cholangiocarcinoma in patients who present with pain, jaundice, abnormal LFTs, and obstruction or abnormality on imaging, we should recommend the following workup: history and physical examination, liver function tests, consider baseline CEA and CA99 levels, consider serum IgG4 to rule out autoimmune cholangitis, multiphasic abdominal pelvic CT MRI to assess for vascular invasion with IV contrast, chest CT with or without contrast cholangiography, and consider endoscopic ultrasound after surgical consultation. So, dear colleagues, this was a brief review about the initial laboratory workup of patients with hilar cholangiocarcinoma.